For this video, I'm going to talk through the basic anatomy of the knee, different graft types that we may use to fix certain parts of the knee during surgery, as well as different fixation options and drilling options when going through some of these different types of procedures. So just to start out, talking about the anatomy of the knee, we'll start by talking about the ACL, the anterior cruciate ligament, which we commonly call the ACL. So its origin is going to be the medial portion of the lateral femoral condyle, with its insertion point being the posterior aspect of the lateral meniscus. Its job is to limit anterior translation of the tibia. So I have a little diagram here that we can see that. You can see the ACL running right here. And then posterior to that, we actually have the PCL, which you can see just behind the ACL here. So the posterior cruciate ligament, also known as the PCL, originates at the anterolateral aspect of the medial femoral condyle and inserts at the posterior aspect of the tibial plateau. And the PCL's job is to limit posterior translation of the tibia. So you can also see that here in our diagram, just posterior to the ACL. And additionally, we have the MPFL, which is the medial patellofemoral ligament, with its origin being the medial femoral epicondyle and its insertion point being the superomedial border of the patella. And the MPFL's job is to resist lateral movement of the patella, so to kind of keep that in place and keep it from translating laterally. It's not labeled here, but you would be able to see it on either knee on the medial portion running transverse to the knee. And then finally, just one important thing to mention as well is we have the meniscus, obviously. So a little bit of a kind of top-down view of the meniscus here, which you can see. So the meniscus can be divided into two different parts. We have the medial meniscus as well as the lateral meniscus, with the medial meniscus being C-shaped and the lateral meniscus being O-shaped. So in addition to having the two parts of the meniscus on each knee, the two portions, we can also divide the meniscus into three different zones, if you will, which you can kind of see here. So these three different zones almost looking like a heat map. So we have the white zone, the red-white zone, and then also just the red zone. So the red zone is going to be the most, the peripheral third closest to the joint capsule, which has actual blood flow. The red-white zone is a bit of a hybrid in terms of blood flow, and then the white zone which is basically completely lacking blood flow. And we divide it amongst those three areas when referring to it during surgery, because the blood flow to the certain areas is going to either promote healing or hinder healing, and that may dictate how we go about going about operating on the meniscus during a procedure. So that's kind of the basic anatomy to touch on. We can get into graft types a little bit now too. So the two main categories of graft types are going to be autografts and allografts. So starting with autografts, which are going to be more preferred amongst athletes and young patients, just because a lot of literature shows that it's you have a little bit better healing, especially for high strain activities, when taking tissue from the patient's body. So the first type of autograft, and which is a very common one that I've seen in the OR a good bit, is patellar tendon. Also, we call it BTB, bone tendon bone allograft. So basically what we do is we take the middle third of the patellar tendon, and basically you have a bone plug on each end, one end being the patella and one end being the tibia, and the center portion being that tendon. The second type of autograft option is going to be a quad autograft, which is typically soft tissue only. It could come with a bone block or bone plug. There's two different ways to do it. But one pro of doing a quad allograft is it's a very robust graft size, so it's very common in revisions when a surgeon may want a lot of tissue to work with. And then finally, the third autograft type that I wanted to talk about is a hamstring autograft. So this is referring to the hamstring tendons, which are going to be used most commonly. We're going to use the semitendinosus tendon. This can be also referring to the gracilis tendon. There's different ways to go about this, but essentially taking the different tendons and folding them over one another is going to make the graft thicker. So when you see this during surgery, they're often long, thin strains of tissue. And so what we basically do is we'll take the tendon and fold it over itself, and then potentially fold it over itself a second time when preparing it on the graft table, the back table. And this is essentially going to be used to create our new ACL graft. This is also commonly used when doing button fixation as well. Next, we could talk a little bit about allograft options. So for allograft, you have all of the same options as autograft. So patella tendon, quad, hamstring, those are all going to be donation options as well from another patient. But in addition, we also have Achilles allograft options and anterior tib allograft options. So a couple things to note when referring to allografts. One advantage of them is, although it's not the patient's own tissue, they can come kind of pre-shaped or in natural raw form, not heavily modified. And an advantage of that is if a surgeon has an idea of how they want to go about a procedure, it can save a lot of time. You can also get pre-sutured options or pre-shaped to a particular size. So this can be used to target a specific type of geometry and is going to just reduce graft prep time in the back, and also could just aid in the flow of the procedure. So just to talk a little bit about Achilles options, obviously this is only going to be allograft because we don't want to damage someone's Achilles in order to repair their ACL. That would be a little bit counterintuitive. But a couple pros of using the donor Achilles as an ACL option is it's a big graft and it can often come with a bone block, so it gives you a lot of tissue to work with when doing a revision potentially. And anterior tib as well, it's going to be a donated tendon. And another pro, it's very easy to work with. For athletes, like I was mentioning, you're often going to want to do autograft options when possible, just because it's going to have better results. So next we'll just talk a little bit, wanted to talk a little bit about just the femoral and tibial sides of this procedure. Those are going to be kind of the main two talking points when going about the procedure. So I have a picture here just of an example drill guide. So we're going to have a drill guide for both the femur and the tibia, but it's kind of going to be the same idea. So within our ACL toolbox, you're going to often see tools like this, which are going to be essentially used to help dictate the angle that the surgeon's going to drill at. And we have a lot of different options in terms of obviously what angle they could set it at, but the different drill types and stuff I'll get into a little bit as well. But as you can see here, these guides are going to help create that angle of approach for drilling our tunnels. So just to talk a little bit about some of the drilling options that we have. For the femur specifically, we'll start with the femur. You can drill anterior medial. So when coming anterior medial, we can use flexible reamers, low pro reamers, or acorn reamers. So flexible reamers are going to essentially, inherent in the name, it's a reamer that is actually going to have a slightly bendable and flexible shaft, which allows you to drill at a varying angle when going into the different tunnels. A low pro reamer, which is essentially like what you would picture when you picture a drill bit. It's a cannulated reamer that's a little bit lower profile, and it's used to ream the ACL tunnels through the medial portal. And then also an acorn reamer, which looks like a typical reamer, but it has a little bit thicker tip, looks like an acorn, which hence the name. And this can be used to a little bit more controlled drilling. Obviously, the whole shaft is going to be the diameter of that acorn, but it can be a little bit more controlled. Maybe if you're only doing a partial tunnel, that can be used as well. And then outside in, which is the next drilling option, which is the more intuitive one to me personally. When doing that, we're going to do a flip cutter. So if we're going to use what's called a flip cutter, which is basically when drilling in, the flip cutter is going to go in at one diameter, and then we can flick a switch and then drill backwards with a varying diameter. So this can allow you to create a tunnel of two diameters without having to change the drill bit at all. So this one's very intuitive to me because you can have that exterior portion be a smaller diameter, potentially for button fixation, with that interior tunnel being a little bit larger to stuff your graft in. And then the final drilling option is going to be transtibial, which is a little bit more old school. It's not as common. It's one of the it's the more original technique. It's not done as commonly anymore, and essentially that's going to involve drilling the tibia and the femur together with one pass, which is not as common anymore because it's not as anatomically friendly. So it is a little bit easier, but it's not going to promote as healing as well, according to a lot of modern literature. So it's a little bit more of an antiquated approach. As far as fixation options for the femur, we're going to have interference screws and button fixation options. So as far as interference screws go, we typically bucket them into biocomposite, PEEK, or metal options. And for biocomposite and PEEK specifically, we're going to lean towards using those for softer tissue, and then we'll lean towards metal options in other scenarios, like for bone, for example. For soft tissue like tendons, we tend to lean to biocomposite and PEEK because it just meshes better with the tissue and promotes healing better. Some example screw diameters that I've seen on our catalog are around 6 to 7 millimeters in diameter, and then around 20 to 30 millimeters in length. So that we obviously have a lot of different options depending on surgeon preference, graft size, patient anatomy. And then in addition, we also have button fixation, which we have a variety of different shapes and sizes of buttons, but essentially what they're going to do is using suture, we're going to fixate the button to one of the cortices, and the other end will be sutured to the graft to kind of create that tension. So that's pretty much sums up drilling and fixation for the femoral side. Just to talk a little bit about the tibial side now, some options that we have for the tibia are full tunnel, which we could do with an acorn reamer, or a full barrel reamer, which is essentially the acorn is going to be a little bit more precise and can be done to a certain depth. One pro of that is there's less bone removal than just going full blown with a larger reamer. And then, like I said, a full barrel reamer, which is typically just used to drill a full tunnel through both cortices. We also have socket options, which are also going to lean towards that flip cutter option that I discussed before. And then as far as tibial fixation goes, we're also going to lean towards both interference screw and button fixation options. From what I've seen, the most common combination is fixating the femoral side with a button, and then the tibial side with an interference screw. Now, there's obviously a lot of different ways to do this. Surgeon preference and patient anatomy are going to be the two main indicators for that, for how we go about those fixation options. And then just finally, I thought it would be helpful to talk about just kind of the general steps for one of these procedures. So like I said, there's different ways to do it. We could do kind of a more hybrid approach. We can do an all-inside approach, also a transtibial approach like we talked about before. I'll talk quickly through an all-inside approach just because that's what I've seen a little bit more of, and I think it's the more intricate of the three techniques. So just kind of the generalized steps are going to be, first, the surgeon will essentially try to get the graft out as quickly as possible. And then if it's an autograft or if it's an allograft, we'll basically begin prepping that on the back table. Oftentimes as reps, we're helping to kind of guide that process with them in the back, keeping an eye on everything. But get the graft prepped, and that involves kind of tubing it to a particular diameter, which we want to do quickly so it has time to sit. And then also prepping the graft to the appropriate length, which is going to be determined by the tunnels drilled by the surgeon. So then after kind of beginning that graft prep process, we'll start with the femoral socket. So that picture that I had showed before of the guide with the drill pin, we'll take the femoral guide and essentially create a femoral socket to the desired length. So we'll ream to the desired length. And then after the femoral side, we'll move on to the tibial socket, which involves using, similarly, the tibial guide and drill, and we'll go to the desired length of that tunnel as well. And we're going to do both of those with all of those drill options that I had mentioned earlier. Once we have our tunnels ready to go and our portals set, we'll then begin to pass the graft through, and the graft will be prepped, like I said, there's a variety of options to prepare the graft, but a couple examples, we may do a button fixation for the graft, so that would involve suturing the graft on one end and preparing that on the back table. When we insert it, then we'll begin by passing the button through and allowing it to kind of fixate to that other cortice. So passing the graft and seating both sides kind of involves pulling the graft through the femoral socket, typically confirming that that button is seated, and then pulling it through the tibial socket and confirming that that button is seated, and then doing our final tensioning would be the final step after that. The ACL specifically, since the tensioning of it is so important, it's such a mobile kind of portion of the body, we want to make sure that we do this tensioning properly. And I've seen surgeons do it in a variety of ways. But that final tensioning and the angle at which you hold the knee and the order in which you tension is going to be very important. And then finally, the surgeon will just typically do some final checks before closing, making sure that the knee has the appropriate mobility and is kind of in the right place. So I think a good summary of the kind of must-haves, if you will, for just going about an ACL procedure is you're going to have a guide for both the femur and the tibia. You're going to have a guide pin, and then we're going to have some sort of reamer. So whether that be acorn reamer, flip cutter, just all of the options that we discussed before, and then also a fixation option of some point to keep the graft sat. So that was a little bit just summary of the knee anatomy. Kind of walked through different portions of the knee. Talked about kind of pros and cons of different fixation options and just the generalized steps for going about one of these procedures.